All right, so I'm going to briefly do an overview of craniofacial sleep medicine. So you guys are already very familiar with the discipline and specialty of sleep medicine itself. When you think about dental sleep medicine, it's kind of an interesting area of work, predominantly based on mandibular advancement devices for a therapeutic point of view. And that kind of evolved historically from dentists and orthodontists who were working on TMD, people with TMJ issues. And in some cases, they would provide them with, a so-called night guard. And really, that was the overlap with sleep bruxism. And as you know, sleep bruxism has a very strong correlation with sleep apnea as well. And then the kind of empirical idea of if you bring the jaw forwards, you can open up the airway, especially in an emergency situation. That led to the idea that you could use these dental devices, oral devices, for mild cases of sleep apnea, and then kind of ventured further into moderate cases. And more recently, oral devices have been used successfully even for severe cases of sleep apnea where the patient is unable to tolerate PAP of some description or declines a surgical intervention, so on and so forth. So you're kind of already familiar with the space of dental sleep medicine. Craniofacial sleep medicine is kind of similar. It includes all of the above, but the emphasis is slightly different because we want to address all four craniofacial tissues. We're not predominantly kind of focusing on the mandible or mandibular position. And four craniofacial tissues, as you already know, are the skeletal tissues. That's the cranial base, the midface, including the mandible. And then you've got the soft tissues, which are predominantly muscles, such as the tongue, muscles of mastication, the constrictors of the pharynx. Then you've got the functional spaces, the nasal airway, the sinuses, the upper airway. And then, of course, the fourth one is the dental tissues, the teeth themselves. And so all of those tissues need to be in a state of stasis, a state of equilibrium and balance for the patient to be both healthy and comfortable. And the idea is to be able to improve the quality of sleep and the longevity of that case. So craniofacial sleep medicine is based both on mandibular advancement devices as a mainstay, but it also includes a whole series of techniques called palatal expansion. And it could be simple devices that the patient can remove. It could be a fixed device that the patient cannot remove. It could involve some kind of a mini implant that's placed by the orthodontist or the general dentist, or it could involve some form of maxillofacial surgery. And so palatal expansion is an umbrella term for just a huge number of techniques that are out there. In addition, we have OMT. OMT is oral myofunctional therapy. And that, of course, is a technique to really improve the balance of the musculature, specifically the tongue, and also its function in terms of speech and swallowing and breathing. And then there's a whole bunch of new techniques coming out there. And so the other techniques are kind of the newer techniques, which we'll kind of discuss a little bit as we go along today. So the treatment options for sleep apnea, OSA, well, the first option is do nothing. I mentioned that in the previous lecture that I gave. A group from Brazil is suggesting that because there's a lack of robust evidence for palatal expansion, that children should be treated. And of course, from a parental point of view, from a provider's point of view, it's sometimes a difficult option to kind of just watch this child suffer as they try to grow out of the condition. Another one that's gaining a lot of momentum or more momentum recently is weight loss, weight management, and looking at patients with systemic obesity and craniofacial obesity to see how that could be impacting their quality and quantity of sleep. And as you know, the mainstay from a sleep specialist point of view is the PAP therapy. That is evolving tremendously. A lot of new techniques coming out there, specifically something like KPAP, which is providing pressure at the time when the airway is most hypotonic and most likely to collapse. So that's also a very kind of helping sphere of work. Then there's a whole bunch of treatments which I'll group as craniofacial surgery. It could be something um, minimal, such as frenectomy, where the lingual frenum is released or removed by either an ENT, an orthodontist, a general dentist, to remove that tag of tissue. The evidence for that is extremely low. However, it seems to be very popular in the common kind of clinical sphere. And that ranges all the way through to various genioplasties, higher suspension, all the way to maxillomandibular advancement surgeries, some of the more complex surgeries. So there's a whole bunch of surgeries in there, including some of the ENT procedures that are done within the nose. And so that's just a whole bunch of options there as well. And then the kind of newer ideas are the surgical implants, for example, the hypoglossal nerve stimulation and so on, and phrenic nerve stimulation. So we can think about that as an option. And then, of course, the mainstay for many general dentists is the oral pines therapy in adults, as well as palatal expansion in children. And both of those therapies have a broad range of protocols and techniques and devices which can be considered. And then there's other craniofacial techniques, which we'll try to mention towards the end of today's presentation if we can. So adult treatments, positive airway pressure. We know that the compliance is an underlying issue which needs to be addressed and is being addressed proactively by the profession. It represents about 85% of the market currently. And of course, the idea behind PAP is to provide this pressure. However, the underlying condition has not really been addressed. So if you take the PAP therapy away over a period of time, there can be worsening of the underlying condition. And we've seen this in the news stories where some high, well-known person forgets to wear their CPAP mask, and has a severe outcome, possibly death. And so the idea here is to say, what is the underlying etiology of sleep apnea, and how can we address it more thoroughly? The other option here again is the advancement devices. The idea is that they're going to hold the mandible forwards and open up the airway. That's a very generic approach. It's an emergency situation. We want to open the airway, absolutely, get the tongue out of the way. However, it's not a simple mechanical maneuver whereby you manipulate the mandible and the air kind of just opens up. And we'll talk a little bit about airway behavior because the biological system is subject to homeostasis. And so if we provide the plain laws of physics to as an inanimate object, they don't typically apply or may not apply fully to a biological system that's got behavior, that's got the homeostatic balances built in to try to reach some form of equilibrium. There's a huge number of mandibular advancement devices out there. They do provide relief. However, if you take the device away, let's say the patient's been using it for 5, 10, 15 years, if you take the device away, the sleep apnea condition typically worsens over a period of time. Again, the underlying condition has not been addressed. And so the third option here is surgery, which is a very advancing field. Surgical implants such as hypoglossal nerve stimulation, phrenic nerve stimulation are in the news. The phrenic nerve is, in cases of central sleep apnea, where the diaphragm is not getting any kind of stimulus from C3, 4, or 5, and therefore you need to stimulate that to get the breathing going again. And the hypoglossal nerve stimulation, as you know, is targeting the genioglossus muscle and trying to activate that muscle to prevent oropharyngeal obstruction by the tongue. Then there's a whole bunch of elective surgical procedures, ENT procedures, there's a whole bunch of those that are done for septal deviation, turbulent reduction, so on and so forth. There are orthodontic treatments that are done to manipulate the jaws, maxillary mandibular advancement, UPPP, hyoid suspension, geniohyoid muscles being attached and being remodeled. And all of these surgical procedures do offer significant relief, but again, there could be worsening over a period of time. And part of that condition or worsening of the condition is because of aging. As a patient gets older, they lose muscle tone, they lose the stem cell populations become kind of depleted. And so their response, the muscle response, is not as good as it was when they were a younger individual. And so that's one of the things to bear about in terms of long-term management of these cases. So in terms of dental or dental sleep medicine, how would you treat mild or moderate sleep apnea? This is going back to 2011. This is Dr. Sestuli's team from Australia. Mandibular advancement splints, he calls them, as opposed to devices, are recommended as a first line of treatment in mild moderate cases, even in severe cases where the patient is unable to tolerate or refuses CPAP or other types of PAP therapy. So the interesting thing here is a mandibular advancement splint, the idea of just holding the tissues mechanically in a specific position and hoping that that will address the underlying condition. And of course, there's a bit more to it than that, as we know from clinical experience over the last 10, 15, 20 years. We've seen how some of these patients respond. And optimal outcomes is when you have a multidisciplinary, interdisciplinary kind of care model where the team is working together to get the best possible outcome for each individual patient. So when you think about sleep appliances, dental sleep appliances, it's interesting. Descriptor is semantics, but in fact, these are really airway devices. They are trying to either open the airway, increase the cross-sectional area of the upper airway, and therefore allow the patient to sleep and breathe during sleeping. And so there's lots of different devices, but as a overall kind of classification, you have the monoblock devices, which are a single piece device. It fits in the top jaw as well as the bottom jaw. Hinge-based devices where you can open and close the device the front. Pull-based devices that pull the mandible forwards. Traction-based devices where you have a screw system so you can kind of titrate the amount of advancement of the mandible itself. And then compression-based where you're pushing the mandible forward. So that's kind of generic type of classification of some of these devices. And so they are fabricated by a dentist in coordination with a dental lab based on dental models and a bite registration. And that's the magic two words, the bite registration. So the idea is to manipulate the mandible to a position to optimize the airway caliber and behavior. So generically, they say, let's do a 70% protrusion. That is an arbitrary figure. It may work, it might not work, but clinically, the dentist is going to try to figure out how to place that mandible for the maximum effect. And so you can use a device built to that by registration to keep that mandible in that position during sleep. It could be any of these devices. I have no particular interest or favorite one. Dorsal appliance, they've got EMA appliance, you've got the TAP appliance, you've got the Oasis appliance. The Herbst appliance here has got a hinge mechanism. The Herbst appliance has been used in orthodontics historically for a long time, specifically in children with, where the mandible is recessed and they want the mandible to kind of grow forwards into a nice position. And this type of hinge mechanism is Medicare approved for adults with sleep apnea. And then, the Pro-Somnus here with a screw-based mechanism to advance the mandible to a very specific position. So when you think about the mandibular advancement device, you can see this patient, the chin is kind of slightly retruded, and then we do an arbitrary superposition with the device in the patient's mouth to take a photograph, superimpose with and without the device, and you can see how the chin and submental region has come forwards. And the assumption here, as the airway has, quote, opened or increased its caliber or increased its cross-sectional area. So for the same patient, where this is the cone beam 3D scan for the same with nothing in the mouth, and you can see the size and shape of the airway here in red. And then the same patient, kind of post-treatment, you can see how the airway has changed. You can see how the mandible has changed also. You see the tongue position has changed, but it appears to be an increase in caliber cross-sectional area of that upper airway. Now, this is what you might call mechanical enlargement or, quote, opening the airway. So we want to see how this airway would behave in terms of upper airway collapse, because that's really the holy grail, is to prevent upper airway collapse. So here's a study that we did back in 2007, and we're looking at the upper airway, and we're going to use a specific condition here, or a technique, and to test, to ask the question, what is the function of a mandible advancement device? And the idea here is its function is to prevent upper airway collapse. And these patients had a history of TMD with a sample that we had available. And so what we're doing in this specific group of patients is doing a very specific jaw registration procedure. It's called the sibilant phoneme registration. In other words, we ask the patient to count using the S sound, so 61, 62, 63, 64, 65. And every time they make the S position, the tongue comes upwards, the airway opens. So we ask them to hold that position, and then we take the bag registration in that specific position to see how this airway is going to behave. So we use a pharyngometer here, acoustic reflectometry, to see how we could image that airway without using ionizing radiation. And we measured the airway at the functional residual capacity, and then we asked the patient to breathe out completely, and the residual volume. And you can see that when they do that, there's a 25 reduction in the volume of the airway when they have the residual volume compared to baseline. Now what we do the same thing, except the patient now is in the phonetic position. They are in the sibilant phone registration position. The jaw has been manipulated specifically based on the speech. And what we found is that when you compare the mean residual airway, when we look at the airway here, look at the residual volume with no device versus residual volume in the phonetic position, there's an 15 to 80% increase in that airway volume. So here it is again, comparing the functional residual capacity with the residual volume. We see a 25% collapse in blue here. And then when you compare the residual volume compared to the residual volume in the phonetic bite, you see a 15 to 80% increase in the caliber of the airway. And so, as well as mechanical type of advancement, we're wondering if this would somehow prevent the upper airway collapse. There's not a lot of choice when it comes to bite registration procedures. It's an area which has been very poorly researched, in my humble opinion. There's only one or two papers out there. It's a critically important position because the dentist should not be estimating or guessing or hoping that they get the right position. There has to be some kind of physiological feedback to say you've optimized the position of the mandible or the tongue. This is a study which has not been done, but it's called the biomimetic bite registration. And you can see this X-ray has been taken of this individual. Look at the position of the cervical vertebrae. And those are kind of important because we are generally looking at the, anterior part of the upper airway, the nasal airway, the tongue, the oropharynx, with very little regard to the posterior pharyngeal airway, which defines the posterior boundary of the upper airway. And that boundary really is, to a large extent, determined by the orientation position of the cervical vertebrae. You can see the airway here at about level of C2, and you can see that the teeth are pretty much in contact and occlusion in this case. And now the patient has had a chiropractic adjustment. So the neck has been manipulated either by an osteopath or by a chiropractic physician. In this case, it was a chiropractor. You can see the position of C2 has changed, and there's a concomitant change with the upper airway. It seems to have increased in caliber, and you see that the jaw has also changed position. That's because the horizontal axis of rotation of the mandible is C1, C2. It's not the glenoid fossa. And so that space you see between the teeth could be the position at which this patient needs to be stabilized using an oral device if we're going to use physiological as opposed to arbitrary parameters to decide where we're going to position this mandible. So the idea is to prevent the obstruction during sleep, is to manipulate the mandible forwards, use a device to hold it there. And of course, there are those patients that respond very well to this type of therapy. And there are other cases where there is little or no response. And so in the case, the upper panel with the responder, you see this increase in the transverse diameter of the upper airway. And in the lower case, there's been hardly or no change whatsoever. And so the question is, which of these patients is going to respond well to a device and which patient is not going to respond well? And what is the underlying reason for that diversity of kind of response? So the idea here is DICE, drug-induced sleep endoscopy, is to find out which patients would benefit kind of from which procedure. And so we're going to put these patients in that condition here. And then I'm going to we are going to manipulate the mandible and then pull it forwards here. And then we're going to look at the response of the upper airway. And what we find is looking at the level of the soft palate, the level of the velum, some of these patients open the airway in an anterior-posterior orientation. Some of these patients open the airways in a medial-lateral orientation, and some people have a concentric pan of opening. So if you manipulate the mandible and it's a case where the muscle fiber orientation is in the anterior posterior direction, you'll get a very good response. In the case of panel C, where you've got a concentric pattern of opening and closure, if you manipulate the mandible forwards, there will be some response. But in the case where there is medial lateral or lateral opening of the upper airway, if you pull the mandible forwards, there will be little or no response. And so this is where DICE is kind of a very kind of useful procedure to say, is this patient suitable for an oral device or not? Looking further down at the level of the oropharynx, again, we've got medial lateral opening, we've got anterior lateral opening, and an example here how the tongue is being compressed laterally. And looking at the level of the base of the tongue, example here of concentric opening, of anterior posterior opening, and lateral opening as well. So you can take this DICE procedure at different levels and decide how suitable this patient is going to be for a mandibular device or some other procedure if indicated. The idea next is to think about cases of moderate to severe sleep apnea. Back in November of last year, this device was cleared for moderate to severe OSA in adults. And the idea is it's the first time that an oral device has been cleared. Not true. It's the first palatal expander to be approved for sleep apnea treatment in adults. So there's a marked difference between an oral appliance, which kind of indicates a mandibular device, versus this device that they're talking about, the DNA device, which is a form of palatal expander predominantly worn in the upper arch. So there are other devices out there which are FDA cleared for the use of in cases of severe sleep apnea. And here's a study we did back in 2009. This device is called a full breath solution. And in this case, in the sample that we looked at, the AHI fell by 73% from about 31 events per hour prior to and about 70 events per hour after the device was placed. And this device is a single piece device. It's a monoblock device, comes in one piece, but it's got this extra extension or this tail. And what this tail does, it depresses the tongue. It restrains the tongue. It doesn't protrude the tongue. It physically depresses the tongue. If the patient can tolerate it without gagging, it will work well for them. But some patients have a hypersensitive gag reflex. And so it's not suitable for all cases, but it's one of those devices that has been used for severe cases in the past. So let's look at these monoblock appliances. A single large device. It's non-adjustable by the patients. It's made of dental acrylic. And historically, it's really a modified functional activator. So if you go back into orthodontic history, orthodontists realized quite early on that you could reposition the mandible forwards in a child. And for some reason, they called it a functional appliance. And this, functional appliance had some form of activation or activating principle, which they didn't know what it was at the time. And so they called it a functional activator. A functional appliance or a functional activator is a mandibular advancement device. The only difference is it's been used in children or adolescents as opposed to adults, and it's been used for orthodontic therapy to bring the lower jaw forwards. And of course, the activating principle, as we now know, is genetic expression. So when you change the position of the mandible, you change the pattern of gene expression, and the mandible grows into that position, not completely, but pretty close to where you want it to be. And we can show you those studies. If you need to look at those studies, we can show you those. But in today's session, the monoblock is used as an upper and lower device in one block of plastic that you wear in the mouth, and it holds the mandible forwards in these adult patients. And so from that historical device, you can see where the ideas came from. This is the DNA appliance in blue. So what I did was to add 6 degrees of freedom and increase its functionality to make sure we addressed all the craniofacial tissues. But that's how these devices have been evolved in terms of medical kind of history. So for this monoblock device that we're looking at here, it was used for severe sleep apnea in adults. It reduced AHI significantly from about 49 down to about 12 events per hour over a period of 3 months, and from about 47 down to 13 events an hour after 1 year of use. And these patients also had an increased overjet at the beginning, which means that they were, the mandible, the chin was receded, so the chin was pushed forwards, the mandible was placed forwards, and so they were good candidates for this type of therapy. And in addition to addressing the sleep apnea, they also showed a reduction in systolic blood pressure because these cases also had hypertension as well as the sleep apnea. And that's not an unusual finding. That study was done back in 2011, and just this year in April, this news piece came out that mandibular advancement devices can also be used for blood pressure modulation in cases of hypertension with OSA, which is comorbid in these cases. I haven't actually fully read the paper myself, but it's in the Journal of the American College of Cardiology. It's something that I want to look at a little bit later on. These oral devices have short-term side effects, things like tooth sensitivity, a little bit of tooth pain, is usually transient. Something a bit more kind of concerning might be issues with the temporomandibular joint, TMD. So before these devices are placed by a dentist or the orthodontist, we want to check the TMJ, make sure it's healthy. We want to warn the patient ahead of time if there's an underlying TMJ condition that may kind of emerge as treatment proceeds. Because these devices do change the position of the temporomandibular joint, specifically the condyle of the mandible and the articular disc will change position. The glenoid fossa, as you know, is part of the cranial base. And so if the patient does develop TMJ issues, pain, limited opening, then the treatment has to be discontinued and the TMJ problems have to be addressed. The longer term effects of wearing a mandibular advancement device include things like bite changes. Some of them are favorable if you have a large overbite at the beginning or a deep overbite at the beginning, they may actually improve. But of course, you can get the reverse as well. So here's a study where the teeth are, the upper teeth and lower teeth are pretty close together. There isn't an increased overjet. There isn't an increased overbite. But this patient wore the device for, several years. And now the lower jaw, the mandible is stuck in the forward position. Now, as an orthodontist, that would be a case I would treat as a, quote, class 3 malocclusion or as an anterior open bite. That's where we were trained, is to say we've got class 1, class 2, and class 3 malocclusions. And so if this case walked in with a mandible protruded, it would be a case to be, looked at. However, this is a preventable issue if we do a thorough craniofacial analysis before we put any device in any case. We can find out what's the likelihood of having these kind of bite changes and positional changes of the jaw. And of course, those jaw changes affect facial appearance. And so patients are also concerned about their facial profile and how these devices might change them. In the right cases, they can actually be beneficial in terms of facial appearance, but you need to be aware of that before you start. So because of these bite changes that are anticipated, it's recommended that these patients do these bite exercises and wear these morning repositioners to put the mandible back where it was the night before. I personally and professionally disagree with that opinion. Of course, you can choose any protocol that works in your hands. And so when the mandible is manipulated forwards, it's an example of clinical decompensation, or should I say compensation. So the mandible showed developmental compensation by being retruded, and then you manipulate the mandible forwards, you decompensate, and that would be a better functional physiological position for the patient. And so the patient, in my opinion, should be finished with that position. But of course, that's a pretty comprehensive undertaking. You need training both in orthodontics, oral surgery, and so on and so forth. And so maybe the simple cases could be done that way. And some of these other cases, you could use a morning repositioners or bite exercises if you wish. Before starting mandibular advancement therapy, one of the important things to do is to look at the cranial base morphology of these cases. And my favorite phrase, as you know by now, is the cranial base sets the pace for the rest of the face. This is the cranial caudal gradient of development. It applies to evolution, it applies to human development, and it applies to clinical applications in the craniofacial space. The second thing to look at is the mandibular plane angle. So we're going to look at the cranial base, look at the anterior cranial base, the posterior cranial base, and the cranial base angle, the saddle angle. And we're going to look at the mandibular angle because not all mandibles are the same. And so that mandibular plane angle can be high in some cases, measurement of more than 120, 122 degrees. You manipulate that mandible forwards, the chances of producing an anterior open bite or a class 2 malocclusion increase. And so we know these high angle cases before you start, you need to warn the patient that that tongue might thrust forwards and you end up with an anterior open bite. And what it means is the front teeth don't touch together when you bite. And if you take a sandwich, try to bite through a sandwich, nothing kind of happens. So we look at the cranial base morphology in adults with sleep apnea. We find that there is a risk factor. We look at the cranial base angle. It's relatively acute, or it's more acute in patients with OSA compared to controls. And in addition to that, the developmental compensation or the postural compensation to counteract that effect is to displace the hyoid bone inferiorly. And so when you looked at the study here, you have a short cranial base morphology, and the blue area here, the impact of that short cranial base is the nasopharynx is smaller in volume. You increase the resistance to airflow. And the compensation for that is to displace the hyoid bone inferiorly downwards and try to, get adequate airflow through the nose, through the nasopharynx, at the back of the nose. So, some of these cases need to be looked at carefully before we decide that we're going to use a device, which device we're going to use. So because of that, we can use the outcomes to predict how successful our therapy might be with an oral appliance. And long story short, made short here, is that the closer the hyoid bone is to the lower margin of the mandible with the device in place, the more likely the patient is likely to have a positive response of wearing the device and to decrease the apnea-hypopnea index. So we look at the distance between the hyoid bone and the lower edge of the mandible here. It's kind of quite large. And you place the oral device in position, and it's kind of decreased that distance. And the chances are that will probably be, quote, a responder or a slightly better outcome in compared to some of the other cases. Now, we talked about the monoblock being a single piece of plastic that goes in the upper and the lower arch. The idea here is to actually split it down the middle and make it into a twin block. So the upper part is separate from the lower part. So the twin block appliance has been used historically as an orthodontist for many years. I did research on this. We published a lot of studies on this. And this is what it looks like clinically. It's kind of a mouthful of plastic, but what it's doing is manipulating the mandible forwards. And these were predominantly used in children and adolescents who had a class 2 case where they had an increased overjet, the mandible was receded, the upper arch appeared to be protruded. So you brought the mandible forwards and then allowed the teeth to come into eruption, into occlusion by grinding down the actual device. And the idea is that you are going to protrude the mandible in these cases, which is fine. However, when you do this procedure, there is a counter effect on the maxilla. It's called the headgear effect. And so as you manipulate the mandible forwards, the mandible is a large and heavy bone compared to the maxilla, which is a light and smaller bone. And so what happens is, is action and reaction kind of is being brought into play. You end up retruding the maxilla. The upper jaw becomes retruded. Now, the same rules apply for a mandibular advancement device in adults for OSA. However, very few people, if anyone, has actually looked at the effect of the mandibular advancement devices on the maxilla in adults. So here's a study that we did in orthodontic cases. We used a pretty elegant mathematical modeling called the spline analysis. We were able to separate the affine and non-affine components. The affine components are the uniform components of change. The non-affine components are the more localized aspects. And partial warp 1, which was the biggest component, you can see here has retruded the maxilla. It's brought the maxilla back. So the idea here is that if you're going to have a twin block appliance, you need to counteract this retrusive effect on the maxilla. And the way to do that, I thought about it, was to say, let's take the upper device and make it into a palatal expander, and then use a lower device to actually bring the mandible forwards. And that was called the DNA appliance or the mRNA appliance. This study done by Dr. Klee Kashida's group. And what they found is that, yes, there was maxillary expansion in these adult cases of sleep apnea. And in this other study that they did, they found that the BOAT, which is biomimetic oral appliance therapy, so OAT, oral appliance therapy, using a mandibular device, and BOAT, B-O-A-T, biomimetic oral appliance therapy, using upper and a lower device with this palatal expansion. It improved the OSA with improved or increased maxillary dimensions. And yet another study done here showing the maxillary expansion combined with mandibular advancement devices in patients with severe sleep apnea improved the AHI by about 55% or about 46% in these cases. What kind of made me smile when I saw this paper was they said that FDA recently cleared these devices. I can tell you that this was done back in 2014. That was a decade ago. And so, yes, people are finding out about it recently, but the work was done more than 10 or 15 years ago. We can go back and look at some of those studies if you wish. So if you look at this idea, the studies show cone beam measured anatomic airway changes with surgery and dental appliance treatment for sleep apnea. The dental appliance they're referring to is, in fact, the DNA appliance, and this was published back in 2011. So, yeah, so there's some kind of difference between straight dental appliances and the craniofacial approach to say, can we be a bit more comprehensive in these cases? So when we think of palatal expansion, we can talk about non-surgical expansion, the example I just showed you, but there's a whole slew of palatal expansions which are surgically based. They could be mini implants, it could be surgically assisted rapid palatal expansion, so on and so forth. So we pick a paper here on surgical expansion, and we can see this adult patient with a diagnosis of sleep apnea. and they have this kind of narrow nasal floor, high vaulted palate. And the idea for the surgical expansion is that we do not want dentoalveolar changes. So you can see here in green, we don't want to really change the dentoalveolar part of things. We really want to target the nasal floor to be able to improve the upper airway in the surgical cases. And so when you look at this paper here, they give two examples. One of a typical palatal expander, you can see that the vector is low at the dentoalveolar level. And so they're saying that we do not want to have that type of change. And what they're using is a mini implant procedure, which is placed high up, just below the nasal floor. So the vector is much higher up, and we want to get nasal floor changes. I love the principle, but the outcome was kind of interesting because yes, they did get splitting of the suture. This is a kind of a symmetric quote fracture of the maxilla. It's been widened. There's sutural spaces have happened, but unfortunately, you do get a dentoalveolar change because the teeth are going to go for a ride with the maxillary bone in which they are attached. And so now you've created a big space of diastema, and it takes, a pretty nice amount of orthodontic skill to close that amount of space. That's an extra tooth right there. And so it's a procedure that can be used. But of course, you have to think about the degree of difficulty, the clinical, capability of doing this. So in this study, the nasal floor width was increased. The transverse palatal bone width was increased. There was a diastema formation, unfortunately. They didn't provide any 3D nasal airway volume, which is a little bit kind of disappointing because the study was done in 3D. However, they did look at the apnea-hypopnea index, and in a kind of similar study, they showed a 60% improvement in the AHI with this procedure, distraction, osteogenesis, maxillary expansion down. So basically what they did was to induce, did an osteotomy in the midline. They then placed the mini implant, and then they gently, slowly expanded the palate. They got a diastema formation, and then they closed it orthodontically at the end. And then the other study, you can see here, 54% improvement from 17 events per hour down to about 8 events per hour using the same procedure. So there is improvement between 54, and 60%. However, if you look at the non-surgical oral appliances, they also show about 50 to 6% improvement in the AHI in adults with OSA. So my question really is, do we want to do an invasive surgical procedure where you may get a similar or the same outcome using some of these craniofacial oral appliances rather than craniofacial surgery? Here's another example here. This is a surgically assisted rapid palatal expansion, and they're going to compare tooth-borne devices with bone-borne devices. And so the procedure was, the changes were assessed after about 2 years, 22 months. And the nasal airway volume increased by about 9.7% in the group with a palatal expander, and about 12.9% in the group with the bone-borne transpalatal distractor. So if you look at the surgical procedure, they did an osteotomy at the level of a LaFour-1. They then did a midline osteotomy right down the middle. They also did a pterygomaxillary disjunction behind the maxilla. This is under general anesthesia. And then they placed either a palatal expander. The top one is a Hyrax palatal expander. So once the surgery has been done, they then expand using that fixed on the teeth, or they used a transpalatal distractor, the lower photograph showing you after the surgery has been done, they turn the screw on the device in the palate there. Now let's compare that procedure with a non-surgical approach. You've got this narrow, high vaulted palate, and this is using a non-surgical palatal expander. And if you ask me, they are similar, except there's no diastema in the non-surgical case. So let's compare the results of the Hyrax approach versus the oral appliance approach. The surgical procedure in one case was the LaFour-1, the midline osteotomy, and then the pterygomaxillary disjunction. The treatment time was about 22 months. In the non-surgical case, the treatment time was about the same. The wear time was slightly lower in the non-surgical cases. The sample size was slightly lower in the non-surgical cases. The nasal volume change was 9.7 in the high-risk group, as I mentioned. It was about 5.6% in the non-surgical group. The advantage here is that there was no diastema, and so we have to wonder whether the nasal volume will change when you constrict the palate again to close the diastema using orthodontic mechanics. So this is the kind of gray areas where we need to look at a bit more detail, saying which procedure, in which case, and for what reasons. So generally speaking, the craniofacial facial patterns in modern adults, you kind of, narrow nares, maxilla is underdeveloped, the mandible is kind of recessed. We have this thyromandibular angle. And, this is a case that was referred to me by the Dean of Medicine, 25-year-old medical student. He'd had a U-triple-P done, and unfortunately, the sleep apnea had not improved. And so we look at these facial appearances very carefully to say which procedure, in which case, and what's the rationale behind it. So case selection is kind of becoming a critical area in terms of management of some of these cases. And we can look at things like the thyromandibular angle, the angle between the chin and the thyroid cartilage here. And you can see that these are facial profiles associated with OSA. As the angle gets bigger, the severity of the sleep apnea seems to get worse. So the angle here is between 90 and 130. It's mild or no sleep apnea. The angle here is increased to about 150 degrees. You've got mild to moderate sleep apnea. And this angle is greater than 180 degrees or at 180 degrees. There's some other things going on here in terms of obesity, and these patients have severe sleep apnea. We did a similar study in 3D. We looked at craniofacial features in adults with OSA compared to the control group. The patients with OSA had increased facial volume and specifically localized underneath the chin in that kind of submental region. You see the dull chin appearance here. And you can see here it's described as the neck circumference clinically. It's a submandibular pannus, this kind of tissue that's been deposited around and underneath the chin. The interesting thing here is that these cases were treated non-surgically using a craniofacial device, and there seems to be some improvement in the craniofacial obesity. Again, another area where further research needs to be done to find out what is the mechanism of these potential changes. Now, if you have craniofacial obesity, then there's a good chance that you have systemic obesity as well. Obesity is a very common, prevalent condition, needs to be looked at very carefully. One of the things it does, it increases the amount of reactive oxygen species. That is going to affect the amount and availability of nitric oxide. There's going to be sympathetic activation. It's going to activate the angiotensin endothelin pathways. It can precipitate things like hypertension, which goes on to lead towards inflammation, endothelial dysfunction, atherosclerosis, and cardiovascular and cerebrovascular morbidity. So when you look at obesity, it's a complex condition with a overlap comorbidity with things like sleep apnea, for example. So when you think about, the visceral fat that's been deposited in some of these cases and how it impacts the cardiovascular and metabolic comorbidities, you have to think about what is this fat doing. It's going to infiltrate into the neck. It's going to put pressure on the upper airway, increase the likelihood of collapse in the supine or sleeping position. It's going to it's going to reduce the lung volume and increase the work of breathing. The ventilatory load is going to be increased by this visceral fat. There's going to be increased leptin secretion. That's going to lead to abnormal upper airway and neuromechanical control. Bottom line here is increased risk of upper airway obstruction. So this is some of the things that we have to think about in terms of patient management. So the area that's kind of emerging is stimulating therapy for obstructive sleep apnea. The response to PAP therapy is quite variable. Some new therapeutic approaches are being advocated, such as hypoglossal nerve stimulation. And this nature of the stimulation is electrostimulation. It's a bit like a pacemaker, but you have a sensing electrode on the diaphragm to say that is there diaphragm movement or not. Then you have this impulse generator, and that's going to provide stimulation through an electrode in the tongue, the hypoglossal nerve stimulation, to try to protrude the tongue and dilate the upper airway and allow this patient to breathe at nighttime. So this is augmenting the neural output from the upper airway. It's going to affect the dilator muscles. It's very different from the pneumatic splinting that's used or the theory behind PAP therapy. And it's quite different from the mechanical therapy, enlarging the airway mechanically with an oral device. So we need to look at this kind of approach in a bit more detail. Other alternatives, well, you can do electrostimulation during the awake phase using a transoral neurostimulator device. You basically place it on the tongue here. It's used in patients with mild sleep apnea. And it had a pretty decent effect. It brought the AHI down from about 10 to about 5 in patients who responded well. You can do other forms of electrostimulation, submental region you can do here. In this study, they used electrostimulation of the genioglossus muscle in patients with sleep apnea. They found there was an increase in the tongue diameter, there was improvement in the RDI, and it reduced the ventricular load in these patients. So this is the kind of principle behind neuro stimulation in the submental region. And we know the physical equations that apply to airflow or fluid flow through a pipe, for example. But of course, we are dealing with a biological system, and that biological system will have physiological behavior. And so we have to think about not just the physics, but also in terms of the physiology. So in these cases, when on the left side, they're being stimulated, you can see the DST is the distance they're measuring here. When they remove the stimulus, you can see that there is a change. And so the idea is there is this caudal traction with the device in place. So this is what the device kind of looks like. They wear it when they're sleeping, and it stimulates the genioglossus. I did a very similar study. This is what I'm working on here. We got a very similar change as caudal traction using this type of approach. And so the idea is that caudal traction is going to put tension on the tissues, the pharyngeal tissues, and reduce the likelihood of collapse. It's going to include the tongue, the soft palate, the pharyngeal walls, and it's going to reduce the airway collapsibility. So it's going to stabilize the airway. The upper airway shows a viscoelastic response. It's not a true elastic system. It's not a physical system. And the viscoelasticity can be described as hysteresis. So we know loading and unloading behavior. The great thing is that when you start to work in this type of mode, you can reduce the airway, the flow resistance by increasing the cross-sectional area of the upper airway, and also improve the muscle tone and prevent excessive relaxation of the muscles, prevent the airway collapsing when it's most hypotonic. So you see here, when the stimulus is applied, you can increase the amount of pressure in the esophagus here, decrease diaphragmatic pressure. And so you've got stimulation of the genioglossus muscle and the pharyngeal dilator muscles, reducing the ventilatory load. The downside is that this is a non-specific type of stimulation. There's several pharyngeal, facial, and neck muscles and nerves that are being stimulated. So it's not very specific. And also, depending on the threshold of stimulation, you can get alpha wave intrusion, so that some patients start to wake up from sleep. However, in the study, they showed that the breathing was improved as long as you use continuous stimulation over the low current to avoid awakening during sleep. Now, to be a bit more specific, you can use anticervicalis stimulation in patients with sleep apnea. And what you're doing here is, instead of doing hypoglossal nerve stimulation, you're doing anticervicalis stimulation instead. And what you end up with is this idea of caudal traction. You start pulling here on the stimulated sternothyroid muscle, And what it does, it lateralizes the upper, what it does, it stabilizes the lateral walls of the upper airway and increases the retropalatal cross-sectional area, so less likelihood to collapse. You reduce the resistance to flow. And the way they measured the flow was use nasal PAP, and they measured the maximum inspiratory airflow, and they found that it increased when the device was stimulating the ansa cervicalis. So ansa cervicalis stimulation increases the maximum airway flow during inspiration, and it helps to prevent airway collapse. Very similar study using anticervical stimulation to increase pharyngeal patency. And these are patients, so some of these patients who had hypoglossal nerve stimulation, but they were non-responders because the lateral pharyngeal walls and retropalatal walls continue to collapse. Again, fiber orientation, it needs to be looked at carefully here. So the chordal traction was applied via the stimulation here, and it increased the retropalatal cross-section. When you combined the ansa cervicalis with the hypoglossal nerve stimulation, there was an synergistic effect, and so it prevented decreases in airway or pharyngeal collapsibility. And it does that through caudal traction of the sternothyroid muscle. These are examples here to show you when the stimulus is being applied and when it's not applied. When it's applied, you get this improved expiratory airflow. When the stimulus is switched off, you get zero airflow. Second case here, when the stimulation is applied, you get improved expiratory flow rate. When the stimulation is not switched on or it's switched off, the flow rate reduces or is reduced significantly. And here's a third case showing you extended use of ACS in combination with hypoglossal nerve stimulation. So if you look at a single expiration, we're going to use cubic spines to generate the interpolation of the curve here in red. So the red is the predicted versus blue, which is expected. That's the decay in airflow prior to using anticervicalis stimulation. And the green line here shows you the improvement in the amount of airflow then. So, and this was done during expiration. So in addition to the airflow measurements, the cross-sectional area with anticervicalis alone improved, with hypoglossal nerve stimulation improved, and use them together, there was a synergistic effect. And so basically, this is a great area for further research and development. And I believe that the future is really addressing both the structural sites of obstruction of the upper airway, as well as the functional mechanism for collapse, to give a more comprehensive, approach to these cases of mild, moderate, and even severe sleep apnea. So thank you so much for your attention. If you have any questions, I'd love to answer them for you or respond to them. And I want to thank you all for being here today. And I look forward to the next session.